Welcome to our video on pre-hospital rapid sequence induction. This is how we do it at the Greater Sydney Area Helicopter Emergency Medical Service. We'll show you the principles of our structured approach. The way we do things is all about setting things up to optimize first pass success for laryngoscopy, making sure the patient is adequately pre-oxygenated, controlling our environment, using a simplified regimen of drugs, and having a plan for failed laryngoscopy. We use a challenge response checklist to make sure things are in place. Let's have a look at a typical mission. En route to the job provides a good opportunity to discuss who's going to do the tube, you or the paramedic, what other issues there might be, such as drug doses in a pediatric patient. Often on scene, the ground paramedics will have already applied oxygen and vascular access. On arrival, introduce yourselves.
I'm Cliff. It's Terry.
G'day.
How's it going?
Oh, good.
What we might do first is swap over to our monitor, if that's okay, Bob.
Yeah, thanks, Terry. Would you be able to get a second line in for us, please?
Sure. Yeah, no worries.
Happy to do that. And Bob, I might get you just to cut some clothes, get him a little bit more
Okay, mate.
exposed.
So your first actions are introduction, handover, cut clothes, primary survey attached to our monitoring, which is the LifePack 15, and make sure a second IV line is while the patient's being pre-oxygenated. We should also be deciding where we're going to be doing the RSI, picking the optimal position, making sure the patient, if possible, is on a stretcher at kneeling height, which provides ideal
Can you hear me, mate?
laryngoscopy
Can you hear me?
positions. Here's a primary
Anyway,
survey.
looks clear. He's not responding to me. Trachea's midline. Can't feel any crepitus, surgical emphysema. Expansion seems symmetrical. No blood on the glove. Let's have a little listen. Just going to look at the sats there. They seem pretty good. There's a reasonable radial pulse. We'll get that blood pressure on in a second. No obvious external hemorrhage. Abdomen's not distended, it's soft. These pupils.
The neurological assessment includes pupils,
eye
conscious
movement.
level, and lateralizing signs.
Symmetrical
It's
reaction
particularly
pupils.
important to document a full Glasgow Coma Scale score assessment
Painful
prior to
response.
anesthesia, because the patient will then have neuromuscular blockade for the remainder
GCS of 3.
of the trip. So once patient assessment is completed, the team decides whether RSI is indicated. We then adapt the environment and find the best place while the patient's being optimally pre-oxygenated. Where is the best place? Just outside the ambulance, stretcher at kneeling height provides 360 degrees of access, which will enable you to do a cricothyroidotomy and bilateral thoracostomies if necessary. Inside the larger helicopter, the AW139 is also an option. There's plenty of room around the patient in this circumstance. In bright sunlight, remember to put a screen up so that you can actually see into the larynx on laryngoscopy. Doing it in the back of the ambulance is a last resort, but definitely
Okay,
an
we're gonna have
option.
to do an RSI
There's
here,
no
mate.
alternative.
Set up the kit dump, please, once the monitoring's on.
So we use equipment from both the major and minor trauma packs and lay them out on the yellow sheet equipment dump sheet, which is silhouetted, enables us to make sure everything is in place. This is what takes the place of your anesthetic nurse to make sure no equipment's forgotten and everything is to hand if it's necessary to provide a supraglottic airway or cricothyroidotomy. The timer shows the equipment dump takes about a minute to a minute and a half tops.
Okay guys, we'll need your help for this anaesthetic. Bob, can I get you to immobilise the neck in a moment? And Michael, have you done cricoid pressure before? Superb, I'll get you to do that standing exactly where you are actually, but you can crouch down on the floor, guys. So Bob, if I take the collar off, have you got the head nice and steady?
I've got it.
That's great. Just going to loosen the collar, but leave it there. And what we'll do is just get your forearms straightened out of the way of the laryngoscope handle. So you might just need your elbows a little bit more around that way. Beautiful. Michael, are you able to just reach over or through? And I reckon the cricoid is about there. And when we say go, I want you to just push down nice and firm as you've been trained. Please keep it on until we ask you to take it off. You guys happy and ready?
Yes.
Beautiful, thanks. We're going to do some checks and then we'll be ready to anaesthetise this fella. Thank you.
So we use pre-filled ketamine and succinylcholine for induction, followed by morphine and midazolam and vecuronium. So the pre-drawn drugs are prepared, the team has been briefed, and then we do the challenge and response checklist. The person who has laid out the equipment then reads off the checklist, and the remaining person checks the equipment is in place.
Continue.
Okay, oxygen supply 2 bottles
1, 2.
and sufficient. Pre-oxygenation in place. SATs connected.
Check.
Suction available and working.
Check.
Monitoring's all connected. ECG, non-invasive, SpO2, waveform,
Check.
CO2, all in place. IV drugs, cannulas connected, fluid, flushed, running easily.
Check.
Non-invasives on the arm.
Check.
Baseline,
Got a blood pressure.
spare cannula,
Check.
induction drawn up,
Check.
label, dose selected,
Yep.
sucks drawn up,
Check.
label, dose selected,
Yep.
post-intubation drugs drawn up and labelled.
Got morphine, Medaz and Vec here.
Okay, intubation equipment, bag, mask connected to oxygen,
Check.
Cadell airways,
Check.
2 nasopharyngeals,
Check.
laryngoscope blade,
Check.
appropriate size, check light,
We've checked that.
tube size chosen, cuff tested,
That's been tested.
alternate
8.0.
size chosen, cuff tested,
Check.
syringe,
Check.
bougie,
Check.
filter, catheter mount, gooseneck and CO2 assembled,
Check.
tube tie.
Check.
Okay, patient assessed for difficult airway
Looks like a routine RSI, no difficult airway features,
and a difficult airway plan and equipment ready should anything occur.
as discussed.
Okay, team brief, ready to go.
Check. Check's complete. Let's release the time.
Once the checklist is completed, there is no need for further delays. You should proceed straight to general anaesthesia, injecting the drugs through the cannula on the contralateral arm to the blood pressure cuff.
Pump that fluid in. Okay guys, cricoid on. Right guys, we're just looking for him to fasciculate. We'll see some muscle twitching as the anaesthetic takes action. Beautiful. We'll wait for that to stop. Stop. See how we're going with the jaw tone.
So following cessation of fasciculations and onset of apnea, we make sure there is flaccid jaw tone, and then laryngoscopy can commence, which is usually performed by the HEMS paramedic. If a grade 3 or 4 view is obtained, then what we call the 30-second drills are enacted, which involves removal of cricoid pressure, external laryngeal manipulation, and either additional suction or a change of laryngoscope blade technique or operator.
Good view.
Bougie is used routinely for all pre-hospital rapid sequence inductions.
I have the bougie.
I'll get the tube.
Remember the anti-clockwise turn to avoid catching the bevel on the right aryepiglottic
Bougie
fold.
coming out. Inflating cuff.
Confirmation of tube position is done by clinical assessment and
Inflated,
waveform
connecting.
capnography, which is mandatory in all rapid sequence inductions.
Bagging, looking for end-tidal CO2. Good work guys, keep that cricoid on for the moment. Thanks Michael.
Secure the tube.
Good breath sounds on the right. Good breath sounds on the left. It's quiet over the stomach and we have a good end-tidal CO2 trace. And cricoid can come off, thank you Michael. Cheers.
We give a dose of vecuronium, 0.1 milligrams per kilogram, and we note the time when that's been administered. For maintenance of analgesia and sedation, we use morphine and midazolam. And I will note the time. So tube is secured, drugs are given, and the equipment is tidied up and collected in the yellow bag that's used for the equipment dump. After delivering the patient, we then enjoy a flight home over the most beautiful harbour city in the world. That's our pre-hospital RSI video. Please also check out the helicopter operating procedure and the RSI manual.
It's not very natural, is it?
That's Terry.
Bye. Now.
This is camaraderie. This is a working relationship.
Do it.
These are the cutouts. So this.
There we go.